Well, hello everyone, and welcome back to Human Biology here at Chaminade University. I apologize, I had to cut lecture 8A in half. I thought I had time to record it before an actual lecture in person, but I did not. Anyway, this is 8A part 2, and we left off talking about vascular resistance and blood pressure. And these two are going to be correlated because the blood pressure is going to be directly related to the vascular resistance, which is how much pressure is exerted on the pressure walls. And so if we increase the blood pressure, that often comes with an increase in blood volume. Usually that comes because of a increase in blood volume. So blood volume will cause an increase in blood pressure. And remember, the heart is going to be the ultimate source of the initial pressure. That contraction of the left ventricle, which pushes the pressure wave out from the aorta, is going to be beginning the pressure of the circulatory system. And anytime that we have arteries that are a little bit narrower, that's going to increase the resistance to this vascular flow, which is going to increase our pressure. And the fact that the heart is constantly going to have a variable cardiac output, so we're going to have high pressure during ventricular contraction and lower pressure during the filling stays, so that's going to alter the pressure constantly within the vessels. And the way that we kind of are going to able to help with this is by dilating our arterioles and our precapillary sphincters to allow the fluid to quickly move into venous circulation. So the blood flow is actually going to spend much less time during arterial flow and a much longer time during venous return. So every time that a blood vessel branches out, it's going to end up forcing it into a smaller and smaller section, right? So every time a blood vessel constricts, the flow to everything downstream will be affected. And if, for example, we have a constriction of this blood vessel, that means that the blood vessel, these guys might get a little bit more. So the tissue that this blood vessel leads to will get less flow because the blood will choose to follow an alternative route instead. So we can regulate the amount of blood that a tissue gets by regulating the constriction of the blood vessels. So these are some of the factors that affect blood flow, including metabolic requirements, your body temperature, your blood volume, and your blood viscosity. So we know that tissues that need more oxygen and nutrients are going to need more blood flow, right? If you're eating more groceries, you're going to need to have the groceries come more often, and you're going to also be making more waste, so we're going to have the trash taken out more often, so we're going to need to have more blood supply for that. Now, the body temperature is directly related to how tightly dilated or constricted your arteries are. So vasodilation happens when we have increased temperature, and decreased temperature causes vasoconstriction. And so if you end up with like a flush, for example, that's because you're a little bit warm and you have vasodilation occurring. All right, so blood volume is going to be, again, directly related to the blood pressure, and an increase in blood volume increases blood pressure, obviously. An increase in blood pressure increases flow to almost all areas of the body because it's directly related to increasing cardiac output, right? And so the most significant organ that plays a role in regulating blood volume is our kidneys, because it's going to play a really strong role in regulation of blood pressure via that angiotensin-renin system. Now, viscosity refers to thickness. So when we talk about blood viscosity, it refers to how thick the blood is, which is determined by how much water is present versus how much hematocrit is present. Typically, the blood viscosity should stay approximately normal. That's one of the big roles of the kidney, is to help regulate the blood viscosity by pulling out water or adding water back in. And if someone is going to have a low red blood cell count, that's defined as anemia. And having an anemic condition can also cause a decreased resistance. All right, so this here is discussing cardiovascular disease. So this has a nice smooth, what we call laminar flow. The blood's going to come nice and clean right on through this vessel. Now, if a vessel is under atherosclerosis or has an atherosclerotic lesion or a plaque, this is going to be a plaque buildup here, mostly of fat. Also got some immune cells in here, and it's filling inside the walls of the blood vessel. This can cause a decrease in normal blood flow, and it can cause like turbulence and oddly shaped, which is going to increase the resistance and decreases flow to that tissue, as well as causes clot formation. A decrease in clot formation. Now, we can change our blood viscosity and our blood volume by changing the medication that we take. So we can do this with over-the-counter medications like diuretics or vasodilators. Diuretics are going to decrease your blood volume, and vasodilators serve to decrease your vascular resistance. All right. So a normal individual has a resting cardiac output of approximately 5 liters per minute. That means every minute we are pumping 5 liters of blood throughout the body. And we define the blood pressure by the force exerted by the blood against the vessel walls. So this blood pressure is going to change slightly as we're going through the beat of the heart, because the pressure is caused by the pumping of the heart, which again keeps the blood circulating, but it's going to vary based on whether or not the ventricle is in active contraction, so like systole, diastole, right? Um, and every blood vessel in the system has its own blood pressure, and it's going to change continuously depending on how much that organ that it surfaces is going to require. All right, so here we're talking about a feedback loop. In this case, we have a stimulus. It's disrupted a controlled condition. In this case, it's disrupted blood pressure by increasing blood pressure. Anytime we have a controlled condition disrupted, we have receptors that detect that controlled condition. In this case, they're baroreceptors. These baroreceptors are going to be responsible for detecting blood pressure, right? Then we're going to have information coming in from the afferent neurons, integrating that information in the brain, which is the control center. In this case, it's the medulla oblongata region of the brain. You don't need to necessarily remember that. And then we're going to have afferent neurons. So afferent going in, efferent going out. The efferent nerves are going to end up going to the heart through the vagus nerve to the sinoatrial node, decreasing the heart rate. And by decreasing the heart rate, we can then decrease the blood pressure. Okay, so this is just one mechanism of blood pressure regulation. Again, we're going to have to use a receptor to detect this. We're using a baroreceptor to detect stretch in blood vessels. If we were going to be detecting chemicals, we would be detecting with chemoreceptors. If we were looking at the osmotic balance, we'd be using osmoreceptors. And if we're looking at the body's position and movement, we're using proprioceptors to detect this. So all of these different types of receptors are going to help us regulate our blood pressure. Antidiuretic hormone, or ADH, is a hormone that's going to increase water resorption by signaling the collecting duct and distal tubule of the kidney in order to keep that water retained. Aldosterone is going to increase sodium resorption, and as you know, water follows sodium. So if we increase the sodium resorption, we're also going to be increasing the rate of water resorption. Now, we also have epinephrine and norepinephrine. These guys are going to increase your blood pressure. They do that by increasing resistance, by increasing vasoconstriction, and this leads directly to an increase in cardiac output. Now, the angiotensin pathway is going to help stimulate aldosterone production, and as you know, aldosterone is going to continue increasing sodium resorption, which increases the water resorption, so angiotensin is going to cause vasoconstriction, etc. And then ANP, or atrial natriuretic peptide, is going to cause sodium excretion in the kidneys, which is going to lower your blood volume and your blood pressure. Remember, when the sodium is excreted, the water will follow. That's going to lower blood volume, which then will lower blood pressure. So ANP is going to lower blood pressure in a couple of ways. It also lowers blood pressure by causing vasodilation as well. All right, so here's the application question talking about heart disease, which affects over 2 million people in Canada and 500,000, kills approximately 500,000 people in Canada per year. The reason that we're using Canada is because you guys get the advantage of open source textbooks, and this one must have been written in Canada, not in the United States. But heart disease affects them in the same way. It causes atherosclerosis, which causes a plaque buildup in the blood vessel walls, and can begin early on in life, as early as age 20, and end up taking decades to appear. However, it's one of the most preventable diseases because there's lifestyle factors that you can utilize. So we want you to make a list of lifestyle factors that you can incorporate to prevent atherosclerosis, and explain why you've chosen each one, why each one is beneficial. All right. So this here is talking about cardiovascular disease as the most preventable diseases, has a lot of risk factors, including body weight, diet, exercise, age, and genetics, as well as diabetic condition, smoking, whether you smoke or not, and the stress on your heart rates. So here's a healthy coronary artery. Here's one that's got plaque buildup. You can see the plaque lesion is going to reduce the amount of space that the blood can flow through, which is going to increase the blood pressure. And this region is going to be lipid rich, so there's a lot of fats here. It's a fatty plaque that's going to line that endothelial layer. All right, so how does body weight affect? Well, if you have extra weight, you're going to have extra blood that's going to have to circulate in further areas, so it's going to make the heart work harder, and that's going to cause an increase in your blood pressure, especially if you carry the weight around your waist. And there's two different ways that we can look at the way people carry weight. Some people are going to carry weight more around their waist, and some people are going to carry it more lower in like their hips. Okay, so we call that like the apple versus pear style of carrying weight. Okay, so these are some of the risk factors for this is going into some of the risk factors for cardiovascular disease, mainly focusing on hypertension or high blood pressure. And here, a normal healthy individual will have a systolic pressure of about 20 and diastolic of about 80. So contracted of 20 and relaxed of about 80. So 20 over 80 is good. If we get into anything that's going to be over 121 to 139, so over 120, then we get prehypertension. Anything 140 or higher is hypertension. 160 or higher is severe hypertension. And we're going to have high blood pressure even in the diastolic moments. So 100 is going to be pretty high for the diastolic resting state. All right, so we have a lot of different types of cholesterol. We have LDL and HDL, and we call this the healthy lipoproteins and the lousy lipoproteins. L for, it actually means heavy and light density lipoproteins, but the L is for bad and the H is for good. And you want to have a ratio of the good to bad that you want to be able to have a good ratio of the good to bad. So your total cholesterol, you want to keep it below 5. Your LDL, you want to keep it below 3.5, and your HDL, you want to keep above 1.5. So you want to try to have a ratio of 1 to 2 of the LDL to HDL. If you end up with bad cholesterol levels, you end up with high LDL and lower HDL, which means that you're not transporting the fats around your body properly, and they're going to end up sitting, or the cholesterol levels are going to end up sitting inside of your cells. So decrease the LDLs. How do you do that, right? That's what your goal is, to increase HDL and decrease LDL. And you do this by diet and exercise, right? Eat less sugar and eat less trans fats and exercise in order to burn off the stored fats. So what happens if we end up with high blood pressure for extended periods of time? So what happens to your body if you have untreated hypertension for years? Well, your heart's going to undergo extreme stress with enlarged load. It's going to cause an increased heart muscle, so the heart's going to actually increase in size to increase for the compensate for that increased load. It also can lead to hypoxia, which is low oxygen conditions in the blood, as well as arrhythmias, which means that you're not going to have a lovely lub-dub. You might have some sort of arrhythmic condition, so the rhythm is going to be off. And you can end up with capillary hemorrhages due to increased pressure, and that can lead to all sorts of problems. Depending on where the capillaries rupture, we can end up with brain damage via a stroke, or retinal damage if it ruptures inside your eyes, lung damage or kidney damage. So whatever organ is going to have the rupture is going to be dramatically affected. All right, so what is metabolic syndrome? Metabolic syndrome is when you have central obesity of more than 35 inches of waistline in females and more than 40 inches of waistline in males, as well as two of the following. So you could have a waist of this size and be extremely healthy if you're the kind of person who is an athlete, right, who is working to maintain their body mass. But the reason that this becomes unhealthy is when you also have high triglycerides, low HDLs, high LDLs, high resting blood pressure, or high fasting blood glucose. So metabolic syndrome basically means that your metabolism isn't working properly, and that's going to lead to a significantly increased risk of death from a heart attack or stroke. So how do you treat this? Eat less salt. We as Americans eat way more salt than we ought to. You can get more than enough salt from just a couple grams of salt a day. So if you're healthy, you want to eat about 3 to 5 grams per day. If you already have hypertension, you want to reduce your salt dramatically to less than 3 grams a day. You also want to exercise at least 20 to 30 minutes a day. Get yourself to about increased cardiac output. Get your heart rate up and get your breathing to be heavy. This is going to help burn off the fats, and burning off the fats is going to help get your LDLs in lower and your HDLs higher. You also want to eat foods that are high in antioxidants. These are going to help reduce your free radicals in your body, and it's going to help make you healthier overall, as well as avoiding eating a lot of trans fats or processed foods, fast foods, as well as sugars. And you also want to make sure that you see your doctor, because if your hypertension has gotten to the point that it's severe and advanced, you're going to want to seek some sort of medical treatment for that. All right, so what kind of treatments could we utilize? We might use diuretics to increase the amount of water that's excreted, or beta blockers, which could decrease your heart rates. We can have alpha blockers, which will affect your vascular heart rate as well by decreasing the effects of norepinephrine. Beta blockers do the same thing, but by decreasing the effects of epinephrine. You can have calcium channel blockers that decrease the rate of heart contractions and also decrease the contraction of blood vessels, which is not quite the same thing as vasodilation, but is going to restrict vasoconstriction, which is important. Vasodilators are also taken, so people who have some heart meds include nitroglycerin, and they utilize that to dilate their blood vessels. We also are going to have inhibitors of ACE, and that's going to mean that we're going to decrease the production of aldosterone, and aldosterone is going to be responsible for the water concentration, and the blood pressure is directly related to water concentration. Or we can have blockers for angiotensin 2 receptors, which is going to also decrease aldosterone production, which again causes vasodilation. So all of these are going to cause, what we want to do is open up the blood vessels so that we can get more blood flow through. And we want to change the heart rate to decrease the heart contraction. And we also want to change the water balance to make it less viscous, which will also cause lower blood pressure. Okay, so what is a heart attack? A heart attack is called a myocardial infarction, not to be confused with a myocardial infection, which is a heart infection. It's also called angina. And so what happens? Well, we end up with hypoxic conditions in the heart muscle, low amount of oxygen in the heart muscle. This is called ischemia. And when a heart gets ischemia, it's typically because we have a decreased amount of blood flow in the coronary arteries. This can happen for many reasons, but typically it happens because of atherosclerosis, so a blockage because of the plaque that's been building up. But we can also have it happen because of a clot that's been thrown that gets lodged and causes a complete blockage. Also, this individual might suffer from hypertension, from a larger heart, from an enlarged heart, because they're suffering from an increased workload. So they're going to have to get a bigger heart muscle to be able to pump that blood at a better rate. So what is a myocardial infarction and what does it feel like? Symptoms are going to be experienced as severe chest pain and pressure. Sometimes they'll say it's squeezing or that it's tight or that it's heavy. You'll always see them clutching their chest as though they are trying to pull their chest away to open it up to allow the heart to constrict. Sometimes it's also experienced initially before this as a radiating pain in the inner left arm. So if you have a really weird inner left arm pain, or if a patient comes in complaining, or if your family member starts complaining of a very strange inner left arm pain, it might be time to take them to the doctor, like right then, so that you can hopefully get them to the ER by the time the myocardial infarction is in full swing. It's typically going to happen because of overexertion, or maybe emotional stress can also cause it. So this can happen when someone is in a situation where they're told that something terrible has happened. They can have a heart attack just from the stress of it, which is why typically with elderly people, they tell you that you're supposed to gingerly break bad news. Tell them to sit down first in case something happens. It can also be exacerbated by having a stomach that's too full or by a decrease in temperature. So if they end up with sudden shock of cold by stepping outside, that can also sometimes cause a heart attack, right? Think grandma got run over by a reindeer, right? Maybe she had the heart attack first and then the reindeer ran her over. Anyway, I'm off topic. So the pain's typically going to be accompanied by an inability to breathe. Sometimes it can be accompanied by nausea or sweating, so they'll end up trying to vomit or sweat. Often this is just because they're unable to catch their breath. Typically it's going to happen for just a few minutes. But if we have an actual myocardial infarction, it's going to last much longer, sometimes hours, and can lead to death. So angina is going to be a minor heart attack, and it might just pass. It might feel like a panic attack or something that might just feel super stressful. I can't breathe for a second, maybe an asthma attack, and then it passes. So sometimes the first several heart attacks are actually not noticed or not reported because the individual doesn't necessarily recognize that they're undergoing a minor heart attack or an angina event. All right, what happens with a stroke? Stroke is called a transient ischemic attack, or a TIA. If we have a TIA, typically it's going to be a precursor to a much larger stroke. TIA is basically going to be when we have a blockage and the blockage stops blood flow for a short period of time and then the blood flow is restored. But if stroke is when we're going to have blockage of blood flow for an extended period of time, and even if the blood flow is restored, we've got severe damage to the brain. So we'll have brain damage that's also going to include headaches, dizziness, weaknesses, blurred vision, nausea, numbness, and altered sense of smell. One of the first things they tell you to do if they think you're having a stroke, you're going to have a droopy face. Half of your face is not going to be functional. They'll tell you to stick out your tongue. If the patient sticks out their tongue and it only goes to one side instead of sticking straight out, it indicates that one side of their tongue is working and the other side is not. This is very not good. So this is going to be an indication that you need to get them to the hospital immediately, because every second counts here. Because every second that the brain is not getting the blood supply, it is actively dying. And it does not replenish itself as well as the rest of the body. So long-term effects of the hypoxia means that we're going to have damage or extensive damage to the cells that were deprived of oxygen. And while we can sometimes increase the effect of, decrease the physical effect, like if you end up having a drop foot or the inability to move one arm, we can use physical therapy to help gradually increase the function of parts of the body that were affected. But we don't typically do that by restoring brain activity to the region that was damaged. It happens because of what's called plasticity, meaning that these areas here are able to compensate for and take on the function of the areas nearby when they stop working. So it's not typically because we're able to restore the function of that area of the brain, it's because other areas of the brain are able to pick up the slack. All right, so let's talk about blood. Blood is comprised of three major sets. The cells, the red blood cells themselves, comprise about 42 to 45% of the blood supply. The plasma is 55 to 58%, and then we have white blood cells as well. So the platelets are going to be involved in the clotting response. The white blood cells are involved in the immune response, and the red blood cells deliver the nutrients and take out the waste. So the plasma is going to be the liquid portion. It has water, obviously ions or electrolytes, vitamins, nutrients like glucose, fatty acids, amino acids. Also got hormones, so circulating hormones that might be involved in metabolism or in the reproductive regions. Also involved, got plasma proteins and undissolved oxygen and carbon dioxide. Additionally, we're also carrying out some waste products like urea, bilirubin, etc. And so plasma is going to be all of the liquid that all the rest of this stuff is interspersed within. It's about 55% again of the total blood volume. Now, what are the ions or electrolytes that are dissolved in here? Sodium, calcium, potassium, bicarbonate, hydrogen, magnesium, chloride. There's a ton of other ones too. These ions, again, they're called electrolytes, and they must be in balance or homeostasis in order to maintain cellular function, particularly when we're talking about the nervous system. So the components in the blood are going to include albumin, which is the blood protein that's involved in maintaining blood osmolarity. Osmolarity is the draw of water from one side to the other, and it has to be maintained very well to make sure that the water is flowing into the blood supply, out of the blood supply into the extracellular fluid, and from the extracellular fluid into the cells themselves. We also have globulins. Globulins are going to have specialty functions. Immunoglobulins you're going to hear of a lot. Immunoglobulins are antibodies, but it's basically any globular protein. So that can be an enzyme or a carrier protein or regular protein or whatever. Fibrinogen is a particular protein that's really important in blood clotting. It's going to be involved in the clotting response where the platelets, who are the blood clotting cells, are going to be typically circulating through the bloodstream, no problem, but when they find an area of damage of the capillary bed or whatnot, then they will bind to that area, and then the fibrinogen will pull them apart to make a nice barrier so that the rest of the blood flows right on past that area that is under construction. Lipoproteins include LDLs and HDLs, like our high density and low density lipoproteins. That L here literally stands for lipoprotein. And that's going to be involved in the cholesterol levels, right? And going to be involved in carrying the fats throughout your body. We also have hormones. Approximately 1% of our plasma proteins are going to be hormones. And I know when we think hormones, we immediately think sex, right? But we also should be thinking metabolism. So hormones are going to be involved in digestion and in all sorts of metabolic pathways as well as the sexual reproduction pathways. Now, we have specialty cells that are called platelets. Platelets are not actually cells. They are cell fragments. They come from thrombocytes, which are cells in the bone marrow. And they do not have any organelles themselves, but they have specialty granules that are involved in blood clotting, which is also known as coagulation. And if you have an aberrant coagulation response, you might be suffering from something called hemophilia. Now, hemophilia is a genetic disorder that's going to be characterized by deficiencies in clotting factors. It was characterized by being kept alive in the familial line of the royal family, which makes sense because if any other individual suffered from hemophilia, they would probably bleed out much earlier on because they are workers are going to be susceptible to injuries, but the royal family was able to be protected from that, passing this down for multiple generations. People with severe hemophilia cannot cut themselves at all, or they have to take exogenous clotting factors. They also will probably carry around with them some of those clotting bandages that also have the clotting factors present on there to be able to utilize those, not just a regular Band-Aid. They will not just stop bleeding like the normal clotting response. If we have vitamin K deficiency, vitamin K is really important in creating the clotting factors. So if we have a lack of vitamin K, we can end up with less of these clotting factors created, so a decreased synthesis of clotting factors. And it's really important to have vitamin K in order to maintain this whole clotting response. And in order for us to be able to get that vitamin K, we get it from our gut bacteria. So this is something that is going to be really important in terms of keeping our probiotics in our system to make sure that we have healthy gut flora at all times. All right, so your erythrocytes are the red blood cells. These guys have a concave disc. They look like a torus. They function by delivering oxygen. Hello, would you like some oxygen? Can I take your carbon dioxide? Hello, would you like some oxygen? Can I take your carbon dioxide? They just do this over and over and over from one cell to the next. And they do that because they have a specialty protein called hemoglobin. It's a tetramer, so it's 4 different proteins bound into one protein, 4 different peptides bound into one protein. And it's going to be able to bind oxygen. It's a ferrous molecule, so it has iron on it, and iron and oxide makes iron oxide, which is rust. So it's going to be a nice red colored molecule, which is what gives us the red color in our blood. That's why if I go back a couple, when we actually spin this down, when we spin this down, you're seeing the red from the red blood cells, which are carrying the hemoglobin, not from the plasma, which is actually a fairly clear or yellowish clear liquid. All right, so red blood cells are going to be very short-lived. They're created in the red bone marrow inside the bones. That's called hematopoiesis by specialty cells. These are called erythrocytes, created by the process of erythropoiesis. And they're going to be circulating through the body for about 120 days until they end up with reaching their shelf life, and then they'll be destroyed by the spleen and the liver, degraded into their parts, and recycled into new red blood cells. And we create erythrocytes from stem cells by a protein or a hormone called erythropoietin. So in response to erythropoietin, we upregulate the differentiation of stem cells into erythrocytes and therefore create more red blood cells. We do this in response to a low red blood cell count, which might happen because we've lost a lot of blood, for example. It might also happen because we're deficient in iron and we don't have enough to be able to create the new blood cells. So this is why making sure that you keep your iron levels high is really important, particularly in individuals with anemia. All right, so now we're going to move on to blood types. Blood types are how antigens and antibodies interact. So we have 4 main blood types: type A, type B, type O, and type AB. And we have an interaction of these blood types in a kind of strange way. So A and B are going to be codominant. That means that if we have both of them, they're both expressed. But A and B are both going to be dominant over O. So if B is present and O is present, we're going to express B. Same thing with A. So if we have A and O, it's going to be expressed as A. Now, if we have blood type A, we're going to have antigens to A, but not antibodies to A. So antigens are going to be on the surface of the cell. Antibodies are free-floating in solution. We're going to have antibodies against B. If we have blood type B, we have antigen B, which means we have antibody A, but if we had antibody B, we'd have an interaction, and we don't want an antibody-antigen interaction. If we have type AB, we have both antigens and neither antibody, and if we have type O, we have neither of the antigens and both antibodies. What does that mean? That means that we are able to accept blood from people based on what their blood type is relative to our blood type. So if I'm type A, I'm able to donate to people who are type A or type AB. I'm able to receive from people who are A and from O. I'm not able to receive anybody from B, right? I can only receive from A and O. If I'm type B, same thing. I can donate to B and AB. I can receive from B and O, but I cannot receive from A. If I'm type AB, I'm the universal receiver. I can only donate to AB. I can't donate to A, I can't donate to B, and I can't donate to O. But I can receive from AB, A, B, and O. Now, if you're a type O blood type, you're considered the universal donor, and they will probably call you every 6 weeks to try to get more blood out of you. The blood bank is who I'm referring to, because they need your blood. Why? Because you can donate to A, B, AB, and O. That makes you the universal donor. This is going to be the type of blood that ambulances carry because they don't know who they're going to interact with and they don't have time to blood type in the field. So no matter what, if we're not sure, quick and dirty transfusion is going to be type O blood no matter what. However, an individual who is type O can only receive from type O. So that's why type O blood is going to be the most coveted blood, because it can go to anyone. And an individual who is type O, who is donating this blood to anyone, can only receive his own blood back. They can't receive any of the rest of the blood. And that's because of the way that the antibodies and antigens interact on the surface. And we'll get a nice chance to get to do that in the laboratory as well. All right, so what happens as we age? So in the cardiovascular system, we have specialty nodes. Remember, one's the sinoatrial node, one's the atrioventricular node, and these guys are going to be responsible for coordinating the contractions of the heart. So when the sinoatrial node starts losing cells, we have an increased chance of having arrhythmia conditions, because remember, the SA node is responsible for coordinating the rhythm. The valves are also going to stiffen up. We can have something called lipofuscin, which is when we have fusion of the lipid barriers, so it's going to cause some problems, and we're basically going to have lipids where we oughtn't. And also our baroreceptors are the receptors that are going to be responsible for indicating the blood pressure become less sensitive. So changes in blood pressure aren't going to be detected as easily, so we might have high blood pressure or low blood pressure that remains undetected. The endothelial cells of the capillaries are going to become slower, become thicker, so we have slower diffusion, so less liquid goes out in a certain period of time. And the vessels are going to become less elastic because we've lost elastin. So we're unable to accommodate for these blood pressure fluctuations. Additionally, the total blood volume can decrease, and the decrease in white blood cell count can lead to an increase in infections. Remember, the white blood cells are like the police officers that are going to make sure that everybody is taken care of in terms of destroying the microbes or the parasites or the fungi that might be inside of our body. So if we have a decrease in our white blood cells, then the infectious agents have a chance to take hold. So we might end up with an increase of infections. All right, so this is our last slide. We're going to answer our application question here. How can we reduce our risk of atherosclerotic plaques? 1, avoid eating trans fats. 2, avoid processed foods, high in salt, sugar, starch, and trans fats, and they're low in micronutrients. Eat less sugar if you can, because sugar is converted into fat, which is transported on LDLs. And we want to reduce our LDLs, so we don't want to have them be necessary for utilization, or we increase the amount of them. Eat more plant foods. They're going to have antioxidants. Antioxidants get rid of free radicals, which are going to contribute to inflammation in the blood vessels. And maintain a healthy body weight. If we have too much visceral fat, that contributes to an increase in blood pressure, and that's a significant risk for atherosclerotic lesions. Exercise several times a week, 3 to 4 times a week, and not just for 10 minutes, but for 20 to 30 minutes, enough to be able to burn calories, reduce your body weight, reduce your stress, and increase your HDLs. This is important. If you overconsume too much alcohol, we can end up with a lack of B vitamins. So if you are drinking heavily, or you know you're drinking heavily, take a multivitamin that evening to help get your B vitamins back in order, so that you can end up with stasis, right? We don't want to have an increase in homeocysteine levels, which can cause problems, which would happen if we have less B vitamins. Also, try to keep your stress under control. I know it's easy to boil over, but this is going to cause cortisol. And when we cause cortisol release is going to increase your belly fat and your blood sugar, because when you're super stressed, your body thinks you're stressed because you're starving. And so it's going to immediately try to pull as much nutrients as it can into the pantry, because it's not sure when it's going to get its next meal, even if that's not the case. It also is going to inhibit the immune system, which obviously can lead to infections. We all know that when we're super stressed, we end up sick, right? So make sure that you take care of yourself and take care of your body, and maintain your cardiovascular health. Thank you guys so much for listening today. Happy studying, and have a great day.